welcome to this PCR Valves Eco session. This is a sponsored session by Medtronic and is a case of TMVR and TTVR case in point session. The title of the session is Advances in Investigational Mitral and Tricuspid Therapies. I'm Azeem Latib from Montefiore in New York, and I'm joined by really two experts in the field and great friends, Modine from Bordeaux and Didier Tchétché from Toulouse. Thank you both for joining us today.
Thank you, Azeem.
Hi, my friends.
So the objective of this session, the three of us are going to be taking you through, is really to make you more aware of the Medtronic mitral and tricuspid clinical trial program, give you some updates on where this program is going, the patients who've been treated, really give you a sense of how the INTREPID mitral program has progressed and some clinical data. We'll then switch to tricuspid later in the session and tell you about the really exciting upcoming early feasibility study in tricuspid, and then really give you a glimpse into the Medtronic pipeline and how really the TMVR and TTVR field of Medtronic will be changing in the next few years. So you see on the screen our program. We'll start really with a number of interesting sessions, all followed by discussion. And I think we're going to get straight into it. So let me, Didier, if you can take us through really the Medtronic INTREPID and Apollo program update and just give us a sense of where the program is right now.
So let's go for an INTREPID program update. Here are my disclosure. So there is an ongoing dilemma concerning mitral regurgitation. It's true that despite the high prevalence of moderate to severe mitral regurgitation, it's always tricky to select these patients and to select the proper therapy for these patients. First, the diagnosis is not that evident, and the quantification through echo remains one of the issue. And second, current guidelines recommend to have an optimal medical therapy plus less CRT for the functional mitral regurgitation patients, but most of the time it's suboptimal when we go for the assessment of the medication. On the other hand, there is a lack of data supporting surgery for functional mitral regurgitation. We know that the COAPT trial has provided good insights and confirmed the good outcomes after MitraClip in selected FMR patients, but this is a very small group of patients. And at last, what we can understand is that the comorbidities associated with functional mitral regurgitations are sometimes tricky to address, whether it be coronary artery disease, tricuspid regurgitation, and sometimes it requires a staged procedure. We have data, we have clinical trials that are ongoing, good clinical trials with robust academic settings, but enrolling the patients is a challenge, and we're going to see that. So you know the device, the INTREPID device, this dual stent technology with a 27mm tri-leaflet valve within the inner stent. No leaflet capture is applied during the deployment, and more than 275 patients have been included within a robust clinical trial program. We will go through each of these trials, moving from the pilot study to the Apollo pivotal trial, and we're going to get a couple of discussions during the session for the Transfemoral TMVR and TTVR EFS. So let's start with some insights about the pilot study. The pilot study was aiming at addressing the safety of TMVR using the INTREPID device in a patient at high or extreme risk for surgery. So the patients have been enrolled over a 2 years period, the last patient being enrolled in July 2017, and MVAR criteria were utilized, and there was an independent clinical event committee that assessed several endpoints, including mortality, stroke, myocardial infarction, rehospitalization, bleeding, and reintervention. When we have a look at the baseline characteristic of the study population, the mean age was about 74 years. The mean STS score was 6.5%, and the vast majority of the patients were in NYHA class 3 to 4. If we move to the right part of the slide to the echo assessment at baseline, you can see that 2/3 of the patient had a functional mitral regurgitation, 20% a primary regurgitation, and the remainder a mixed disease. LVEF in more than 60% of the cases was between 30 and 50%, and 50% of the patients had tricuspid regurgitation, telling us about the complexity of that pathology. So in terms of first, what is most visible and the pathology that is treated, mitral regurgitation, the patient had a dramatic improvement in the mitral regurgitation grade, moving from severe in the vast majority of the cases at baseline, from none to mild at follow-up up to 2 years. And this was really impressive. Apart from the safety, the efficacy of the device was demonstrated. So in terms of hemodynamics, the average EOA was between 3 and 4 centimeters square, with a mean gradient that remained around 6 millimeters of mercury all around the follow-up up to 2 years after the procedure. So constant hemodynamics, apart from the mitral regurgitation that was eradicated. And what we could also see from a clinical, from a functional perspective, there was a clear improvement in NYHA class that moved from 3 to 4 in almost 90% of the cases at baseline, to the vast majority of the patients being in class 1 or 2 during follow-up, with a constant pattern all through the follow-up up to 2 years. So here is an example just to illustrate that, and you can see that 5 years post-procedure, this is a TEE at 5 years. We have a device that is in place that is nicely anchored, no LVOT obstruction, no regurgitation, and no gradient. And this is definitely the type of result that we may expect if we find out what is the proper patient to select and to treat with this device. The Apollo trial pivotal study was designed to initially compare TMVR using the INTREPID device via a transapical approach to surgery. So the patients were assessed by a multidisciplinary heart team, and they were divided into 2 arms. One arm, on one hand, patients still operable, with a one-to-one randomization between surgery and TMVR with the INTREPID, and also a risk stratification according to the type of regurgitation. On the other hand, when the patients were inoperable, there was a kind of ongoing registry with a single arm cohort with TMVR, and that cohort integrated MAC. So the primary endpoint was all-cause mortality, disabling stroke, reoperation or reintervention, and cardiovascular hospitalization at 1 year. But if you look here clearly on that side, it tells us about the challenges of enrolling suitable patients within this type of trial, because you can see that 65 centers were activated across US, Europe, and Japan. More than 1,000 patients were consented, but only more than 200 patients were approved. And this was due to some anatomical factors that we may discuss afterwards. And also to make sure that the outcomes were appropriate, there was a quite meticulous pre and post-operative care policy to make sure that the patients were handled in the same way. There was the pause due to the COVID-19. Now 85% of the cases are restarting enrolling patients. But it's challenging to enroll the patients. We've seen that the co-op provided good insights into the efficiency of H2H therapy for FMR, but some patients are not suitable candidates for FMR. And on the other hand, some patients are not suitable candidates for surgery. So we have challenges to find suitable patients for the type of trial like the pivotal trial. So there was a need to evaluate options for patients that may not be suitable either for the transcatheter H2H therapy or the surgery. So this has led to a kind of redesign of the Apollo trial. Still this multidisciplinary heart team assessment, but one primary cohort with patients treated with the TMVR, by TMVR with the INTREPID, and also once again that stratification according to the type of regurgitation. And on the other hand, there is a MAC cohort undergoing also TMVR. And MAC is really something that is that makes sense because it broadens the scope of patients that can be treated, and you can clearly identify that mitral regurgitation is not a single entity. There is a lot of heterogeneity among the patients that we have to treat. So to conclude with the MAC cohort and just the inclusion criteria. The patients are included within the trial if they have a moderate to severe mitral regurgitation with the presence of MAC, or patients with moderate mitral regurgitation and mitral stenosis with the presence of MAC. So definitely, we're going to get a better understanding on the outcomes, performance of the device in this particularly difficult population to tackle. So I'm going to stop there, Azeem and Thomas, and open up the discussion.
Thank you, Didier. That's a great presentation, and you know the data is really convincing. We keep going back and forth as we discuss, you know, mitral regurgitation, particularly FMR, between repair, replacement, done transcatheter. And I think COAPT has at least helped us understand that treating FMR and reducing mitral regurgitation with a transcatheter technique is beneficial to patients, right? But there's still a lot of patients that we either cannot treat with a mitral clip, or even when we do treat, the results are not as good as COAPT, right? And I just say this, you know, yesterday we spent 4 hours on a mitral clip case, right? Where we thought we were going to have a good result. We put one clip in, it's okay, put another clip in, the leaflet gets damaged, and then we're sitting there for hours. There's still a level of unpredictability when it comes to edge. So when I think, Thomas, you as a surgeon, I mean, and you see these data for Apollo and, you know, and for Intrepid, and let's take away just for a second that there are challenges with patient selection. I mean, it just seems like such a reproducible procedure. What do you think the future is going to be for TMVR?
If I go back to the slides that Didier presented, I mean, he showed clearly that we have now reaching almost 300 patients that have been treated with a severe comorbidity background, and many of them with the sustainable results over time, tackling the mitral regurg remaining, I would say, after the case, having, I mean, with the consequence clinically of improvement of NYH class. So we have a therapy that showed to be effective. It had a small safety issue, I would say, with regard to the access. So and we know as a surgeon, as you said, some patients are not good candidates for, even if they are FMR for repair. Some DMR are not good for repair. And we use in our daily life a replacement as an option as a choice. So I see no reason why, if we want to translate the surgical practice to the percutaneous practice, not to have the same problems, the same limitations, and the same advantages of using a replacement over repair. And I will add to this that percutaneous repair has nothing to do with the surgical repair. You don't clamp, you don't open you are not as aggressive, you don't provoke any additional, I would say, injury for the heart, no ischemia reperfusion, you preserve all the submitral apparatus. So definitely, I would say 2 major advantages: predictability, easy to learn, easy to achieve.
Didier, you showed, you know, I think one of the most exciting slides for me that you showed, besides the reduction in MR in the transapical, is how the study has changed and the study design has changed. Can you just maybe tell us what you think, you know, the impact of that is going to be for this program? Because I think this is a very exciting study change and important.
I think it's clear that this is going to support a wider inclusion of different type of patients, because one of the real advantages of this platform is to be able to treat a broader type of anatomies. So we've discussed that with Thomas. Some patients are not suitable candidates for surgery, and this was the purpose of the first part of the trial. Now it's more about exploring TMVR for any kind of patients, and so I do believe that we're going to be able to treat more patients. The device is safe. The device works in terms of regurgitation. It's really impressive. So we're gonna now explore it in a wider population and different anatomies, and this is going to be more suited to a daily practice.
And also, I think it will improve enrollment because, the kind of patients where we're considering TMVR are not patients we want to randomize to surgery. I think that's an important point. Both, Didier, both for me and you, though, when we see the Apollo data, the one thing that holds me and you back is the fact that it's transapical, right? And we want transfemoral. So it's only right to ask the surgeon to show us about transfemoral, because even the surgeon, our surgical friend here, knows that transfemoral is the way to go. So Tamar, can you tell us and take us through the transfemoral transeptal Intrepid system, please?
It's a great pleasure for me to share this with you. And I mean, I may be an unusual surgeon, but I was always a believer of in the need to move from transapical to transfemoral. Again, any evolution should take us in the direction to what is safer for the patient. Okay, so it's my great pleasure to be able to present the INTREPID Transfemoral early feasibility study, and I'm going to show you also 2 cases that have been done recently by 2 great friends and colleagues from US. Unfortunately, this therapy is not available yet in Europe, but hopefully it will come soon. So just these are my conflicts of interest, of course. And quickly, the system, the attributes of INTREPID has been redesigned in order to be able to go transeptal. This is a short video just to show you that once you have been inserting the guiding catheter in the left atrium, just as you do it for a usual edge-to-edge repair procedure, the valve is advanced over a catheter, which shape is completely different from what you know already. This is an approach where you implant from the atrium to the ventricle. And this is nice because it keeps the learning curve that we had with the transapical approach similar to what we want to achieve with this transfemoral system, with the valve being started to be implanted in the atrium and then moving to the ventricle, anchored at the level of the annulus, and then released. So these were also one of the objectives that we wanted to be sure that we could achieve in order not to lose the efficacy and the safety of what we have learned already. And this is a big challenge. So 2 major studies, I would say, in terms of early feasibility approach. One is for mitral, Didier have mentioned this, and the other one for tricuspid. Azeem will be talking more about that. The study in the mitral space is enrolling and enrolling fast. 8 patients have been done so far, 10 sites, and the target is to hit the 15 patients and before moving forward. If you look at the iterations that we have been able to get today, we are moving from the transapical to the transfemoral system. We still have a transfemoral system with a 35 French. I think in the future we will be able to reduce the Frenching of the catheter itself in order to make the consequences on the anatomy of the heart much impactful. And this is also a target that we are all working hard on it. The future is very promising. So far, 275 patients, Didier mentioned this, with enough data based on what we know from the field to push the FDA to accept to move from a randomized control trial to a single arms design trial, which is very important also, because this therapy is different from what we have, and showed clearly that the landscape of mitral regurg is evolving. And I think this is very encouraging in terms of investment clinically from us as physicians, but also from the industry in order to help us getting better devices that we could use for our patients, either if they are not operable or at high risk for surgery. So this is the first case I want to share with you. The 2 cases are different in that one addresses primary mitral regurgitation and the other one secondary mitral regurgitation. This case has been done by our friends Firas Zahar team from Oregon University Hospital, and I'm very thankful for him to accept to share this case with us. Quickly, this is a patient, old patient, 84 years old, severe mitral regurgitation. If you look at the risk calculation risk, is very, very high. This is not a patient that usually we do in any type of study. Dilated ventricle and high pulmonary hypertension. So if you look at the anatomy of the patient, the echo shows clearly that there is a severe mitral regurgitation, a multi-jet mitral regurgitation, and it's a primary mitral regurgitation. I will not spend a lot of time on it. What we usually encounter in elderly patients with degenerative mitral regurg, or primary one, is the following: is that we have some MAC. It's restricted to the annulus itself, but this shows you the challenge if a surgeon wants to operate on these patients, especially in this age, that the risk of operability is higher. We rely a lot on valve oversizing. The INTREPID valve is a self-expandable device, and we need some perimeter, CC, and also AP oversizing in order to achieve a good anchoring. Also, what is interesting to share is that once you have being able to push the system into the left atrium and start the deployment itself, you will use exactly the same views that you are used to with the mitral clip, for example, or the transapical implant that you used to have. So you see on the echo screens on the upper and left ones that when you use X-plane, the brim start to extend with the capsule of the valve diving into the ventricle. You have to be able that you have to be sure that the brim is aligned and parallel to the annulus itself, both on AP but also lateral and medial views. And once you're happy with the position, you are orthogonal to the mitral annulus and you are parallel, you can finalize the deployment itself. We still use rapid pacing in order to be sure that you will have a good touchdown at the level of the annulus. And once you have a good contact, you quickly deploy completely the valve. And this is what it looks like. It's exactly the same thing as we have with the transapical approach. It shows you that it's a quick procedure, no paravalvular leak, low gradient, low LVOT gradient, which assess the safety and the feasibility of this device. So this is the first case I wanted to share with you. It's a degenerative one again. The second case from our friend Amal Gada from Pinnacle, Pennsylvania. And thank you, Amal, for sharing this also case with us. High-risk score patients, severe mitral regurgitation, dilated ventricle, and pulmonary hypertension patients, and not kind of patients that you jump on easily. Secondary mitral regurgitation, and you will see some small differences, but of importance when you do the case. Do regurgitant jets or orifice. The difference between the first case and the second is the absence of MAC calcifications that could help you during the case, because it adds a landmark when you want to do the deployment. Again, the sizing the same based on oversizing, and like the first one or the previous one, the size of the valve was a 48, and on the left part of the screen, the fluoroscopy, the capsule is sliding or progressing in the ventricle. The brim is getting open in the middle of the left atrium. You use a echo X-plane to be sure that the brim is fully expanded. You are aligned to the annulus and orthogonal with the mitral annulus also, and then you are ready to complete the deployment. You use rapid pacing, you push the valve further, you put it on the annulus, you finalize the implant, and the valve is immediately functioning. This is the echo control. It shows the internal disc of the INTREPID valve that houses the pericardial bovine tree leaflets. The outer disc is achieving the anchoring. You see that it's beautifully working. On the 3D echo also, it shows that the anchoring mechanism is really very efficient. No gradient, and very efficient to achieve. So quickly, I wanted to share these two cases with you that shows that early feasibility study with the Transfemoral system is very promising, and we are looking forward to be able to use this on a bigger scale studies in US and Europe.
Thank you, Jamal. That was excellent and really exciting for all of us who believe, Transeptal, transfemoral is the way to go. We want to avoid making big holes in the apex, especially in these patients with severe mitral regurgitation and a low ejection fraction. Great, thank you. So it's a pleasure to talk to you about the INTREPID Transfemoral Tricuspid Valve Replacement program, and take you through really, where this has come and where we're going. So these are my conflicts of interest. So what was the rationale for, and is the rationale for thinking of transcatheter tricuspid valve replacement? As many of you know, there are a number of devices that are now approved in Europe for transcatheter tricuspid valve repair, but we have realized that there are a number of challenges when it comes to the tricuspid valve and transcatheter treatments. In particular, the tricuspid valve is not the same as the mitral valve. Besides anatomically different, and the fact that it has 3 leaflets and up to 40% of cases, 4 more leaflets, makes it more challenging for edge-to-edge therapies. Also, the structure is different. The leaflets are more fragile. The annulus has less tissue and is less able to support annuloplasty devices. Also, the annulus is less well-defined compared to the mitral annulus. Remember, there's no calcium. We don't see tricuspid annular calcification. TAC does not exist in humans. And so the annulus is less well-defined. And also, when it dilates, can become extremely large and much larger than the mitral annulus. But probably for me, what's been one of the most challenging parts in trying to do these procedures has been the imaging. Transesophageal imaging is getting better and better. We're learning more and more how to standardize the imaging, but the fact that the tricuspid valve is so anterior and far away from the esophagus makes it really an imaging challenge to get great views in order to be able to put devices that require you to see the leaflets and leaflet insertion with great clarity. So replacement will really eliminate TR. Compared to the left side, there's no risk of outflow tract obstruction. And probably you have one solution that can treat both primary and secondary TR, and probably also patients with lead-induced TR, with those patients who have pacemaker leads across their valves. So I think it really, the potential is quite large. So the INTREPID valve, it's the same valve to be used on the right side. And really the idea is to leverage this atrial brim. The valve will anchor on the annulus without capturing the leaflets. There's minimal oversizing that's required, particularly on the right side where the pressures are less. And really there's no atrial protrusion or profile with the device. Here you see some pictures from cadavers. Before moving on to humans, the valve was well studied in animals and cadavers, showing that it could be implanted successfully in the right position and was not going to interact with anatomy. There's really been, on the preclinical work, no issues seen with the right coronary artery. As far as conduction disturbances, really we're only going to learn about that as we do more cases. So here you see an image from one of the first-in-man cases. So these are early compassionate use cases. There have been a handful of compassionate use cases. The system is the same system as the transfemoral system in the sense that it gives you multi-directional steering. You really can, visualize well the valve under fluoroscopy. Remember, we do CTs as we do for the mitral, so you get a good plane in which you can be coaxial to the plane. It uses the current profile device, which is 35 French. And really you see here how slick and smooth the deployment is in the tricuspid position. So the FDA has approved the early feasibility study of the INTREPID for the tricuspid and given it breakthrough designation. Myself and Vinny Bappert are the PIs of that study. We'll be enrolling 15 patients in 11 sites for this. Like I said, some compassionate use cases have been done, and we can talk about that during the Q&A. But I've been very impressed when going to one of those cases, how predictable and smooth that procedure was with really great clinical outcomes. So in conclusion, I think we all know that the tricuspid field is growing. We've all realized it's a large unmet clinical need. Many of these patients are not offered any intervention. Replacement really is a really interesting option being investigated for patients with severe TR. I think, it really has, on the tricuspid side, I think replacement has the potential to become the default therapy for the tricuspid because it can treat such a large, broad spectrum of patients and is applicable in such a large group of patients and completely eliminates TR. So the first human procedures have been performed with INTREPID with good results, and we are about to start enrollment in the early feasibility that's been approved by the FDA. And so hopefully next year, when we do the symposium again with Thomas and Didier, hopefully the three of us will be in person doing this. Thomas and Didier, I can show you some actual clinical cases that we treated with the INTREPID and the tricuspid. Didier, you've used a lot of technologies, and there are a lot of valves out there right now, right? People trying to get TMVR right. INTREPID, I mean, we've looked at it, but I think it's important to highlight for the participants. It's unique in the way it's deployed and the way it anchors. Can you maybe just highlight what the differences are and what you think the potential advantages are of INTREPID?
Yeah, I think this is a key question, and it's true that when you see the design of the device and the way it deploys, it's quite a secure deployment because you deploy the atrial portion first to the brim, and then you secure it with the mitral annulus, and then you deploy the interleaflet part of the device. So it's clearly something that is a two-step deployment, and that doesn't need anchoring on the leaflets, grasping the leaflets, putting a ring first without naming the other devices. This is a simplified deployment, 2 steps, very reproducible, and that's what we want. We want to make sure that if we go for a procedure, it's going to be reproducible, and we're going to deploy the device exactly where we want in the sequence that it's meant to observe. And I wanted to ask both of you, do you think that we need for this type of device recapturability? Because we've seen through the cases that it's really reproducible in terms of deployment. Does it need to be recapturable or at least repositionable based on your experience?
Didier, this is an excellent question. Honestly, based on my experience with the transfemoral deployment, and especially in cases where you don't have a good visual and landmarks at the level of the annulus. Sometimes also the anatomy is challenging because the septum is small, because the left atrium navigation is difficult, and the orientation of the heart also, sometimes the axis. I think at least in the beginning, this feature will help you securing the case. Sometimes you arrive tilted and you based on the expansion of the valve, which is self-expandable, to adjust, and it doesn't happen. So I truly believe that at this stage, it's going to be very, very helpful to secure the cases. But I agree with you. I mean, the more experience we have, the more cases we will do, this feature will be less and less used.
Yeah, I'll respond to that as well, Didier. I think it's nice to have, okay, but I don't think it's essential. I just, looking at how this device is deployed and the fact that, before you start opening the device and opening the brim, you actually have the opportunity to put the delivery system coaxial, check your depth and trajectory. That gives you a lot of security that actually you're going to be able to do the case. And the other thing I like, and I think this is really that will get us to the next presentation, which is on tricuspid, and that has really attracted me about this device, is the fact that when you open the brim, you push it down, okay, patient's still stable, and then you release the device. And from an imaging point of view and from an anatomical point of view, it's actually very stable and very safe. The big difference here compared to many competitor devices is the fact that you're not trying to grasp leaflets. Okay?
Exactly.
And the fact that you're not trying to go below, have anchors that go around and grasp onto the leaflets, I think gives you a level of safety you don't have with many devices. And that's why probably recapturability is not a big deal, but probably also, you can recapture this device if you wanted to, right? Imagine a device that has arms, and you go down to the ventricle, you start pulling back, the device is not coaxial, you're damaging the anatomy or interacting with the anatomy, it's now too late. You could never recapture that, right? Because you're already entangled in the mitral valve apparatus. So I think this device lends itself to recapturability. It'll be really nice to have, but you're probably hardly ever going to use it.
That's also my feeling.
Yeah. The other thing I really like about the device and is the fact, I think the part that I mentioned is that it doesn't use the subannular apparatus to anchor, which means from an imaging point of view, it's probably easier, right? Because you just have to check that the device is coaxial. And I think that maybe is a great segue to the tricuspid valve, where imaging is a huge challenge.
So please drive us through the tricuspid transfemoral program.
Let's go on to the tricuspid, like Didier said. So Didier, I think, we have what Medtronic has planned in their pipeline is very exciting. And I think addresses some of the changes will address just really your last question to Thomas about size, about needing bigger valves, and about frame size. But I think it gives us a little bit of time to also talk about the Medtronic mitral and tricuspid strategy, right? Which I think has really grown in the last, probably year or two. I remember, thinking many years ago, when you think of Medtronic and the mitral and tricuspid, it was just, INTREPID and transcatheter mitral valve replacement. But if you look now, I think that's become very different. And there's a large portfolio that Medtronic has. So it's not just anymore replacement of the mitral, it's also replacement of the tricuspid. It's moving everything transfemorally to try and really treat a larger group of patients and provide us with a procedure that's simple, reproducible, and effective. There's also, I think Medtronic is working on getting a large repair portfolio. And I want to show you really one of those devices that I'm not sure you've seen before, but I think is potentially very interesting. And could be, something so different, it could really be groundbreaking. So let's look at how sort of the INTREPID innovation has started. Remember, it started with a first generation transapical device. Now we have a recoverable second generation transapical device. We have the first generation transfemoral system, which is 35 French and is being currently used in the EFS. But there's already, they're working and will have in the near future a 29 French transfemoral system. So really decreasing it 6 French, right? And I think for most of us, that's our safety margin. We want to be under 30 French to go transfemorally, particularly transeptally. I think that kind of hole we all feel comfortable with in the septum. And I think also for venous access, it becomes a less issue. And I think all these changes allows us to treat a larger group of patients with this valve. Here, just showing you, how big the difference is. I mean, 6 French is really, for me, a big difference. One, it will decrease vascular complications that you mentioned, and you're concerned about Didier as far as venous access is concerned. But also for a transeptal system, it means, a smaller hole in the septum, which may not need to be closed and which could close spontaneously. We mentioned also that there's some patients who have larger annuli. This becomes particularly important on the tricuspid side. And so there will be an INTREPID XL valve, which will be a 54 millimeter outer diameter size. And by having this valve, and if you look at CTs that Medtronic has on file from the Apollo program, where they've screened a lot of patients, having this extra valve size will allow them to treat probably just close to 97% or more of patients who were screened for the Apollo trial. So I mentioned the fact that Medtronic now is moving into repair as well, and transcatheter mitral repair. And they announced a few weeks ago this really innovative partnership with the Foundry on really combining, working together to develop a new device and a partnership on this new device. Some of you may know the Foundry. The Foundry is responsible for bringing to us eValve, which then was mitral clip, 12, which is the Intrepid, and the RD wheel denervation system, which is now available as Simplicity. And the Foundry has developed this new device, and the company is called Half Moon Medical. And I'd like to show you a little bit what this device looks like and how this device works. Here you see what the Half Moon medical device looks like. This is a coaptation augmentation device. You see it here, there's a left atrial stent, and then it has this baffle that attaches to the posterior leaflet. It's been designed to eliminate regurgitation by restoring the physiologic coaptation in a diseased mitral valve. So it's really intended to restore valve coaptation. It augments the surface of the posterior leaflet to fill the regurgitant orifice while maintaining the normal function of the anterior mitral valve leaflet. The device is delivered via transvenous transfemoral access. It's fully repositionable, recoverable, and really is potentially, broadly applicable to a large group of patients, both with DMR and FMR. The other interesting thing is, if you have this device in and for whatever reason the patient would develop a second pathology or recurrent MR, you could still put an Intrepid valve into the center here, and so you are maintaining future options open for reintervention. I have a little video to show you just how it works and how this device is implanted. So you imagine, that FMR patient with a small or very tethered posterior leaflet. You put this device in and you create really a coaptation surface, okay, for the anterior leaflet to coapt against. You see how this baffle attaches to the posterior leaflet and how it moves with ventricular contraction. And you can also imagine how, if need be, you could put a valve, an Intrepid valve in the center here if you needed to in the future. So in conclusion, hopefully I've shared with you some of what the portfolio for transcatheter replacement repair will be for the treatment of MR and TR for Medtronic. You saw the data for the INTREPID TMVR program, where close to 300 patients have been treated. I think an exciting feature is the fact that the Apollo pivotal trial has been redesigned to focus really on the patients who I think are really going to benefit from this technology. So inoperable patients who may not be optimal clip candidates. I'm very excited, as is Thomas and Didier, about the fact that this device is now available in a transfemoral version. And so we can do this, without a transapical option. I think also very exciting is that, this technology, once you learn how to use this technology, you'll be able to apply it on both atrioventricular valves, so both in the mitral and the tricuspid. And with a second generation device that goes under 30 French and a larger valve, it means we'll be able to treat a large group of patients and will be broadly applicable. We're about to start here in the US and New York, the study with Half Moon. So hopefully when we see each other again, we'll be able to give you some clinical data. We're hoping to treat our first patient before the end of the year. And I think it's a very different device and could be potentially, I think, disruptive, particularly for a large group of patients. You think of how many patients we see with wide open MR with very minimal posterior leaflet or lots of posterior leaflet tethering, or patients with small valve areas, for example, where I think this device could be potentially very important.
Thank you very much, Azeem. That was a very exciting lecture. So when it comes to transcatheter tricuspid treatment, if we do the parallel with what we do with the edge-to-edge therapy, imaging is crucial. Based on what we've seen, fluoroscopy seems to have to play a major role in the deployment of the device on the tricuspid side. Based on what you know, the experience that you had through case reviews and the training, do you think that it will be mainly a TEE guided procedure or fluoro, or a kind of combination moving back and forth from one method to the other one?
Yeah, so I think in moving forward, it'll definitely be a combination. I think fluoro adds so much in these procedures, particularly if you have a good coaxial plane. Sometimes the right coronary artery not always, but if you see on the CAT scan, it's a really good marker for the annulus and very parallel to the annulus. You could also put a Y into the right coronary artery and use it as another marker. But essentially, it's going to be a lot of it is going to be TEE based. You know, one of the things we're using a lot, and I'm not sure if you guys are using, is the 3D MPR on TEE. And we're using that now for all our tricuspid procedures. It's become almost like standard imaging for us. So we really will, even if we can't get a perfect alignment on the tricuspid annulus using 3D MPR, you can, you know, get your two views. So at least you have two views, one to see septal lateral, and the other one to see anterior posterior, and then you can really get your coaxiality. Okay. Having said that, I think, you know, give it another 2 years from now, 3 years from now, we're going to be doing, and this is my prediction, transcatheter tricuspid valve replacement with INTREPID using 3D ICE. Because, you know, I think 3D ICE is offering such amazing images of the tricuspid valve because you're so close. And with a device like INTREPID, where you don't need to see leaflet capture, you just need to confirm coaxiality and that you push, the brim is touching the annulus. To me, the future is going to be that.
So thank you. So I have a question for you, Thomas. We know that the tricuspid annulus may be extremely dilated as compared to the mitral annulus. So one of the challenges of this technology will be to offer devices that are large enough to cover some of the patients that we will have to treat. So this will probably come initially with a bigger profile of the catheter. Do you think from a surgical perspective that the venous access is going to be a problem, an issue for these patients? What is the trade-off? How do you foresee that in the future?
Yeah, Didier, this is an excellent question. I mean, so first, to answer directly your question, the venous system is a capacitive system. So you could insert in it the bigger sheath. It's not an issue. Just you have to be sure that in some cases you may need a small surgical cut down, close correctly the vein. It doesn't matter. It doesn't do any harm for the patient in case you want to implant a bigger valve. But I think it's important to know that there we will be facing, I think, a limit of reducing the Frenching if we want to make a bigger valve. And from that perspective, we may need in the future like we have it in TAVI, in some cases where we need, I would say, a surgical alternative access. So why not using it? And again, the target is to eliminate the valvular disease, whatever the path is, if it's safe for the patient.
So thank you very much. That was an excellent talk.